16 is the endocrine system, and we have a lot of organs that are secreting hormones. And generally speaking, the endocrine system, endocrine. Endo means inside. Crine or crine means secretion. So these are the glands that does not have ducts to take it outside. If it does have a duct to take it outside, you call it the exocrine. Exo means out, right? Just take everything like this. Endocrine and exocrine. This one does not have a duct. It's ductless, no duct. So the secretions will be secreted in. Just go out. Just leave the gland. There is no duct to take it all the way out. So this is endocrine. So this is the first thing. Number two, it secretes hormones. And we will talk about the hormones. The important point here is, whether you remember it or not, I'm refreshing your information if you did this before. The top management of the whole system is the hypothalamus. Like this is the CEO or the manager of the whole endocrine system. It's overseeing everything else. Followed by the pituitary gland, I will call it like the vice president or something. So the hypothalamus is the president, the pituitary gland is the vice president. Okay? So what's going to happen is, hypothalamus being the head, the president of everything, it's going to issue orders. And these orders will not go to the endocrine glands or organs. Will not. They will not understand it. It will go to the pituitary gland. And the pituitary gland will take the orders and it's going to issue its own orders that the other glands understand. So let's say the hypothalamus wants the thyroid gland to secrete thyroid secretions. It will not send it directly. The thyroid gland will not understand that. It will issue an order that go to the pituitary gland. The pituitary gland will take it. Okay, I got it. You wanted the thyroid gland to secrete. That's fine. Put it aside. I'm going to write my own order. And my own order is the one that's understandable by the thyroid gland. So there will be some secretions, go from the hypothalamus to the pituitary. Pituitary will make its own orders and send it to all these organs. There is no direct communication between the president and other individuals, right? Just take it like this. Plus, both of them being the president and vice president, they will say, okay, this is not the only thing that I'm going to do. In my spare time, I'm going to produce a couple of hormones as well. I'm not just sitting here and giving orders. I will do my own hormones as well. Just a couple of them. Okay? So this is just the general structure, and we will go to the details. So what are all of these? The whole endocrine system, what are you secreting? Hormones, chemical messengers. These messengers will go and act or interact with receptors. They have to go to receptors. And there will be a negative feedback that we will talk about, and this is what's going to control how much secretions. We will understand it. The hormones usually fall under one of these categories. We're not going to go through all the details, but just briefly to understand, it's either peptide or steroid. Steroid is lipid. Peptide is a group of amino acids, like proteins, right? Put amino acids together, you get a peptide. Put group of peptides, you get proteins, right? So it's either protein or lipid, basically. If you still remember, the membrane of the cells is made of double layer of phospholipid. Does anybody remember this? The membrane is phospholipid. Phospho what? Phospholipid. Lipid. It's lipid, right? So lipid, like steroid, can cross the membrane. Lipid pass through lipid. It crosses the membrane easily and goes inside all the way to the nucleus and enter the nucleus, interact with the chromosomes and tell them what to do. How about the peptide? Peptide is a group of amino acids. Amino acids does not interact or does not cross the lipid, right? Like if I get, you remember hydrophilic, hydrophobic? If I get some water and put protein in it, it will sink, right? If I put some lipids, it will not, it will float. They don't mix. Lipid mix with lipid. So peptide will not cross the membrane, being lipids. So how is it going to do the job then? It's supposed to cross the membrane, enter to the cell, go to the nucleus, interact with the chromosomes. This is a lipid. This is not lipid. It cannot do that. So it's going to interact with receptors on the top of the membrane from outside. And this is what we need to know in this part. Why the chemical nature is needed. So we will have the hypothalamus, pituitary gland, president, vice president, and all these glands will be discussed. So we see the steroids, and the question is, where are the receptors that the steroid work on? Membrane or nucleus? Steroid. Steroid is lipid.
Yeah.
Lipid cross the lipid. Can go inside to the nucleus. So steroid work on nucleus. Proteins or peptides work on membrane receptor. Great. This is extremely important. It is anatomy, it's physiology, I understand. You have to know it anyway. Okay? Extremely important slide. You have to know this. Okay? I usually don't focus much on physiology and anatomy, but this, you have to know it. Okay? So let's take it one by one. Number one is the hypothalamus. What's the hypothalamus secreting? Hypothalamus will secrete two things. Orders and its own secretions. We said that from the beginning, right? Mm-hmm. Being the president, I'm going to issue orders. Plus, I'm going to do my own hormones. Orders. What kind of orders? Something like hypothalamic releasing hormones, and these are the orders to do. Do this, do this, do that. And hypothalamic inhibiting hormones, don't do this, don't do that. This is just generally speaking, okay? So in this table, you have to know all of this. The names, where is it secreted from, and what is it going to do. If you don't know this, not only that you're going to lose some questions, but you'll not understand what's coming from the abnormalities. Is that clear enough? You have to know this. Those two are the hormones that are secreted by the hypothalamus. Remember I told you, hypothalamus will issue orders, do or don't do, plus a couple of hormones, right? What are the two hormones? My spare time. I'm not just giving orders. I need to do my own job, right? I have to help, participate. So it's going to do what? Secreting those two. ADH and oxytocin. This comes directly from the hypothalamus. Are we following so far? Okay, what's the ADH and what's oxytocin? ADH, if you read it, you will understand it. ADH, anti-diuretic hormone. The hormone that's against diuresis. What's diuresis? Diuresis. A lot of urine. Diuresis. Okay? Diuresis means you make a lot of urine. Means you lose water, right? This is against that. So what is it doing? Keeping your water. Keeping your water. Water reabsorption. Did we get this part? ADH. How about oxytocin? Oxytocin is a hormone that stimulates the smooth muscles. Smooth muscles of what? Uterus and breast. Uterus and breast. Uterus during delivery. At the time of delivery, the uterus contracts to push the baby out, right? And especially for ladies, if you saw that or if you experienced that, sometimes if the delivery is taking much time, they give you Pitocin. Do you know the Pitocin? They inject it in that saline and it goes IV, right? But the Pitocin is just a trade name or a name for a pharmaceutical name for oxytocin. They give you oxytocin to augment the uterine contractions, right? What else? Breast. What do you need in the breast? If the baby is trying to get the breastfeed, trying to suckle, this irritation or stimulation of the nipple is going to send the feedback, releasing oxytocin, and oxytocin is going to contract smooth muscles around the mammary glands, pushing the milk out. So in both cases, it's contracting smooth muscles. Where? Breast and uterus. Are we good so far? So this is for the first one, which is the hypothalamus. Did you get the 4 for the hypothalamus? We will apply that later on. 2 orders do, don't do, and 2 hormones. The next one will be the pituitary gland. Pituitary gland will issue orders and its own secretions as well, not just vice president. You need to do something. What are the orders? ACTH, TSH, and FSH, and LH. Those 4. ACTH, adrenocorticotropic hormone. The hormone that's tropic to the adrenal cortex. Understand it. Understand it. Do not just memorize. ACTH, each name is coming from a reason. They don't give random names. Adrenocorticotropic hormone, what does it mean? A hormone that's trophic to the adrenal cortex. What's trophic means? Trophic means stimulate the growth or stimulate the function. This is trophic. So anytime you see trophic, know that this is stimulating the function of, or stimulating the structure of. Are we good so far? So what is this hormone doing? Just read the name. It is stimulating the adrenal cortex to secrete its hormones that we will see later on. Okay? That's for the ACTH. Most importantly, there are different hormones, but the most important is cortisone. It's even coming from the name, cortex, cortisone, cortex, cortisone, okay? This is the most important one. Next one is thyroid stimulating hormone. What do you think this will do? Stimulate the thyroid gland from the name, right? Next one is follicle stimulating hormone. What does it do? Stimulate the follicle. What's the follicle? The follicle in the ovaries that produce the ova. Stimulated to grow and secrete. LH, luteinizing hormone. Luteinizing hormone, the hormone that luteinizes. What luteinizes mean? Means producing the luteum. What's the luteum? The corpus luteum. What's the corpus luteum? The egg or the ova that's produced in females is within a follicle. Then it will be released out. The remaining is called corpus luteum. Because you're doing this, I call you luteinizing hormone, LH. This is in females. In males, it will have a different function. FSH for the sperms, LH for testosterone. So in males and females, it's doing different functions. Do we have follicle stimulating hormone? Do you have a follicle like females? It's not a follicle, but it's something similar to the follicle, which is what producing the hormones. Okay? What's producing the sperms, I mean, right? And for the LH, it's secreting the testosterone. Okay? What is produced directly from the pituitary gland? We have growth hormone. It's secreted from the pituitary gland. We will discuss all the details, but this is what is secreted and why, to begin with. So, did we get the 4 orders that are secreted from the pituitary gland? What else is the pituitary gland doing besides giving orders? Do you do your own hormones, participating, helping the rest? Yes, I do. I'm going to produce growth hormone from the name. It's a hormone of growth. It's going to stimulate the body to grow, obviously. Stimulate the body to grow by stimulating protein synthesis so that your body grow, especially in kids. The next one is prolactin. And prolactin from the name, pro means before or leading to, right? Pro, with, in favor of. Lactin is lactation, isn't it? I think it's easy. Prolactin promote lactation, right? So you got 2 that are produced directly from the pituitary gland itself, beside the orders that we talked about. What else is produced? From the pancreas, you have 2 hormones. Both of them are secreted in the pancreas, but they have the opposite action. Insulin and glucagon. Insulin to decrease the sugar level, the glucose level. We know that people have diabetes, they take insulin shots, right? Why do you take insulin shots? To lower down the glucose, right? But you have another hormone secreted from the pancreas as well that do the opposite job, which is increasing glucose. So what's secreted from the pancreas? Insulin, glucagon. Insulin, glucagon. Insulin, beta cells of islet of Langerhans. Islet means island. There are islands in the pancreas. Okay? So beta cells secrete insulin to decrease sugar. Alpha cells secrete glucagon to increase blood sugar. Okay? Insulin and glucagon. Next one is the thyroid gland. Thyroid gland is going to secrete thyroid hormone. Thyroid gland, thyroid hormone. But there are two hormones, T3 and T4. Okay? One is more active than the other. What else is secreted from the thyroid gland? Calcitonin. And calcitonin is a hormone that decreases calcium level. Decrease calcium level. Next gland is, this is thyroid gland. If you look in the back, you will see 4 small glands in the back of the thyroid. And this is the parathyroid gland that secrete parathyroid hormone. And the important thing about the parathyroid hormone is increase calcium level. Okay? This is very important. Any dysfunction will depend on this. So we need to follow this as we go. So this is for the parathyroid gland. So remember, thyroid is not only secreting thyroid hormone, it's secreting also calcitonin, which is against parathyroid hormone. Parathyroid hormone increase calcium, calcitonin decrease calcium. Are we good so far? Okay. We said in the adrenal cortex, you have cortisol is the most important one. And in cortisol, there are a lot of things that we will need to know, and I will talk about it later on. Most importantly, it's to deal with stress. To deal with stress. If you are stressed right now, if I get your blood sample, I will see the cortisol going up. It helps you to cope with the stress. Stress. They call it the stress hormone. This is not the only thing that's doing. It suppresses the inflammation, suppresses the allergy, and a lot of other things. We will discuss the details. Okay? The next one from the cortex is aldosterone, and aldosterone stimulates sodium reabsorption. Aldosterone from the adrenal cortex stimulates sodium reabsorption. The other two here are epinephrine and norepinephrine. Epinephrine and norepinephrine are secreted from the adrenal medulla, or medulla, which is like this. Remember, this is a kidney like this, right? You have the gland here. What is this gland? Adrenal gland. The cortex, which is a cover from outside, secreting cortisol and aldosterone. This is not it. This is the most important that we have to know. There are other things, but this is what we have to know. Okay? How about the inside? The medulla from inside. Epinephrine and norepinephrine. Okay? These are relatives, like cousins. Just a little bit of a difference. But the most important thing to know here is epinephrine is the one that's doing the work when you have a sympathetic situation. What's a sympathetic situation? Fight, fright, flight. If you're fighting, right? If you're fighting, this is a sympathetic. Norepinephrine, there is a unique function for it that you have to remember. Norepinephrine, unique. Vasoconstriction for the parts that's not needed at the time of stress. Vasoconstriction of the parts that are not needed. If you are in the middle of the fight, you don't even have to memorize anything. I'm fighting right now. What am I expecting? Your heart rate goes up? Of course, right? Breathing rate, respiratory rate goes up? Of course. Do you concentrate more? Yes. Do you need the blood to go to your skeletal muscles so you can fight? It's common sense, isn't it? Yes. Blood go to your heart, to your lung, to your skeletal muscles? Of course. Right? Your eyes dilate? Yes. Your respiratory passageways to dilate so you can breathe better? Of course, yes. It's all common sense, right? Do you want the blood to go to your digestive system? No need for it, right? Why would you send the blood in the middle of the fight to your digestive system? Do you need to send it to the urinary system? Is that a good time to make urine and go to the bathroom? Wait, just give me a minute, go to the bathroom, come back real quick? Of course not, right? You're in the middle of the fight. Suppress urinary system, suppress reproductive system, suppress digestive system, right? Everything here is common sense. So what's unique about norepinephrine is vasoconstriction, generalized vasoconstriction of anything that's not needed at the time of stress. Did you get this part? Control of the endocrine system, most important is this word. Negative feedback. The most important of all. It's not the only one. There are other ways, but this is the most important one. Negative feedback. Negative feedback. What's the negative feedback? Simply like this. Let's say I'm the hypothalamus, right? She's the pituitary gland, if you don't mind. Pituitary gland. She's the thyroid. Treasure. You're the thyroid gland, right? I'm the hypothalamus. So I'm going to produce TRH. I want the thyroid gland to produce more. I'm going to issue my order, TRH. We'll go to her, pituitary gland. She will read it, okay? They will not understand that. I will issue my own order. She will issue TSH. TSH will go to the thyroid produce hormone, right? Thyroid hormone. Thyroid hormone is produced. More. Accumulating, right? Enough. I'm accumulating. The thyroid hormone itself will come to me, stop sending orders. I'm accumulating. So I will decrease the orders that I'm giving to the pituitary. It will also go to the pituitary, stop sending orders. So it will decrease the orders going to the thyroid gland. And this is called the negative feedback. More lead to less. Okay? Did we get this part? This is the main one. Okay? Is that the only one? Not the only one. There are some hormones, if it's increased, just release the opposite hormone. Not just send the negative feedback, you can also secrete the opposite hormone. Example, insulin. Blood sugar is going down. What should I do now? Release glucagon to balance it, right? Another way of control, which is called release the antagonist. The antagonist. And the antagonist of insulin is glucagon. The antagonist of parathyroid is calcitonin. Parathyroid is increasing calcium, right? Increasing calcium. Calcium is too much. What's calcium going to do? Suppress negative feedback to the hypothalamus and pituitary, right? Not the only thing. You also have the option for calcitonin. I wanted to decrease it. I'm telling you, stop sending orders. Not enough. Not enough. I can also produce calcitonin to oppose the action, right? So this is the feedback. There is an exception for that, just a little bit, which is the positive feedback. And this is very exception. Just two scenarios that we need to know. Everything is controlled by negative feedback. This is the main control. This is the most important of all. Negative feedback. This is the big one. What's the positive feedback? Sometimes when you do something, you need to do it even more. Example, childbirth. Right now, there is delivery, okay? The uterus is contracting, right? Pushing the baby out. Do you want to stop, or do you want to contract even more to push it out? You want to contract more. So this contraction is pushing out. The cervix will be dilated so that the baby goes out. The cervix is dilated. It will send even a signal to give you more oxytocin to contract more. And when you contract more, you send another signal to send you even more. So more leads to more. This is positive feedback. Okay? Is that clear? More leads to more. It's supposed to, if it's negative feedback, a lot of contraction, send the signal, less contraction. This is not the case. Blood clotting. Blood clotting is another example. You're clotting the blood a little bit to stop the bleeding. The more clots, you send the signal to send you even more until you seal the area that's injured. So these are the only exceptions here. So this is a negative feedback, and he's giving you example of the pancreas releasing glucagon from alpha cells versus insulin from the beta cells. It's the opposite. So blood sugar goes up, you secrete insulin, less glucagon. Goes down, produce glucagon, less insulin. Okay, so remember that negative feedback is the most important thing. And the rate of secretion of the hormone follows something called a cyclic pattern, most of the time. What's a cyclic pattern? It's not like you're opening a water tap and dropping water. Okay, it's not continuous. It goes like this. And you stop. Gush, stop. Gush, stop. This is called the cyclic pattern. Because if you produce it like this, it will do the opposite job. So remember that just that it's cyclic. Now the endocrine disorders, every gland, do we know now what each gland producing? The disorders are when you produce more, when you produce less. Each one of those will be discussed. Okay? So what's the most important factor for increasing more? Benign tumor. By the way, when we go through this, remember this. When we go through anything, causes, 1, 2, 3, 4, 5. This is not enough. You have to know the most common. This is even more important. Okay? So don't tell me it is the liver and the kidney and increased secretion by tumor and it might be negative feedback. No. Yes, these are the causes, I understand. But which one is the most important? You have to focus on this. So if I ask you excess hormone, yes, I know that all these are factors. Which one is the most important? And which one is the most common? And you will remember that later on. So I'm telling you from now, benign tumor. What's the most common? It's not enough to know the reason. It's more important to know what's the most common. What's the most common here? Benign tumors. Tumors is number one. Okay? So what else? Basically, you have excess hormone. You have a lot of hormone, right? There are one out of two reasons. Either you're producing too much or you're not excreting, right? Like if you're opening the water tab and the sink is getting full. Increase, right? One of two reasons. Either too much water coming or less drainage, right? So either you're secreting too much, you're not excreting, one of those. Or maybe combined, right? Maybe you open the water tap too much and the drainage is blocked. Both of them, right? So there are one out of two reasons. Increased production, most commonly it's benign tumor, sometimes congenital conditions. Well, I have my thyroid gland larger and producing more. Why? Congenital. I was born like this. Okay? So two reasons for producing more. How about excretion? Where do you excrete or get rid of your hormone? Kidney or liver? If your kidney or liver are not doing the job, the kidney and the liver is just like the drainage, right? The drainage. So the liver and kidney are not breaking down the hormone and getting rid of it in a good rate, right? So it has to be one of those. But what is the most common for increased hormone? Benign tumors. How about reduction? It's the opposite. The opposite, right? One of them is tumor. You just said tumor increase the production, right? No, some tumors are dysfunctional. Dysfunctional tumors. So the thyroid gland is like this, right? It's enlarging and becoming like this because of the tumor. And you're expecting too much hormone, right? No, it's dysfunctional. So enlarge, compressing the functional part, producing less. So does the tumor produce more or less? It depends. It depends. Is the tumor in the active cells or other cells that are compressing the active cells? Did we get the idea? So tumor can cause increased production or decreased production. Right? The other thing is atrophy or surgical removal of the gland. The most common example of that is, and this is something that's known for all medical professionals, when you remove the thyroid gland, the parathyroid in the back is too tiny, like this. If you saw that in the lab, very tiny. So if this surgeon is not good enough, he can cut the thyroid and cut the parathyroid as he's working, right? So this can be surgical removal. Or maybe you removed it for another reason. Maybe there is a tumor or cancer or something, you removed it. Surgical removal anyway, and atrophy is something else. Congenital deficit, my thyroid is like this. Why? Congenital. I was born like this. Okay? Maybe the receptors. We don't have receptors. What does that mean? It means you're producing the insulin, for example. You're producing thyroid. Everything is okay. Thyroid, go to the cells. No receptors. Less receptors. We mentioned in the beginning that you either have receptors in the nucleus or in the membrane, right? What if you have less receptors, but the hormone is fine? Yes, it will not do the job. Or you're producing too much antagonist. Right? Parathyroid hormone, you're producing, everything is fine, but you see that the calcium level is going down because of the antagonist. Diagnostic test, that will be for everything, so unless we have something special, I will tell you. But this is the vast majority. First thing is common sense, very simple. If you wanted to know if you have high or low hormone, get a blood sample and tell me how much do you have, right? Blood sample. Check the serum. RIA or RIA, radioimmunoassay. You can get some protein or something, label it, and give it to the body. The body will take it, produce hormones, and you can track it. It's radioactive. You can do urine test. Why are you doing urine test? Because if you have too much thyroid, you will have too much waste product of thyroid, right? So you can measure it in the blood or in the urine, right? You can do any type of scanning, ultrasound, CT, MRI, any imaging in general that tells you what's happening. The last thing is biopsy, and biopsy is reserved for certain cases. Specifically, if you're suspecting cancer or something. You get a sample, a biopsy, put it under the microscope on a slide, take a look at it, see if the criteria for cancer or something is there or not. Treatment depends on the reason, the cause. Low hormone or high hormone. Tell me the reason. I tell you the treatment for it, right? It's not all the same. Tell me what's happening, and I will treat it accordingly. I can give you some medications if there's nothing else that can be modified. I can, if the gland is getting too large, I can surgically remove it or remove part of it, and so on. And so it depends on, or sometimes you do that through radiation. It depends on the reason. Now, insulin or blood sugar, this is the most important topic here. We have all the hormones, we'll go through it anyway, right? We'll go through all the hormones. But insulin, glucagon, or insulin specifically, blood sugar, this is the most important of all. It's the big chunk, but this is the one that we will go into all details, so this is the most important thing. Expect to see a lot in this. This is the most important topic, the major topic here. So we have to know this. So, insulin and diabetes mellitus. The insulin is produced from, we did that in that chart, and I told you, pancreas. Which cells of the pancreas? Beta cells. Alpha cells produce what? Which is the opposite.
Yes.
Right? Okay. So beta cells of the islet of the Langerhans is producing insulin, and insulin increase or decrease blood sugar?
Decrease.
Insulin decrease.
Insulin decrease or increase?
Decrease.
Why do you take insulin shots?
Increase.
To decrease it. It decreases blood sugar. Okay? How do you decrease blood sugar? Here is the most important part here. How do you decrease blood sugar? How insulin decrease blood sugar? It do like this. This is the cell. Okay? Glucose enter the cell. Glucose enter to the cell. The cells take it, break it down, get energy out of it. This is the source of energy. You don't have energy, you die. Okay? As simple as this. What is pushing glucose inside the cells? It's insulin. Okay? So this is the most important one. So how is it reducing the level of blood sugar? How is it reducing glucose? Pushing it into the cells. You need insulin so that glucose enter to the cell. When it enter to the cell, you break it down, you take the energy out of it, the cell survive. Everything is okay, right? Push it into the cell. Is that the only thing? No, this is the most important one. Right? All our cells need insulin? No. There are some exceptions. CNS, kidney, heart, myocardium specifically, gut, and skeletal system. Those, they don't need insulin to take glucose inside. Anything else, it does need it. It does. So all other tissues, they need, and you need to know this, any other tissue in your body need insulin. You don't have insulin, you don't get glucose, you're not going to die. There is an alternative. But you're not using glucose anymore. Can you use glucose in other tissues if you don't have insulin? The glucose is going around in the blood. I can't take it, right? I can't take it. I need insulin to push it into me, right? So what will happen in the following scenarios? You don't have insulin. You don't have insulin. Why you don't have insulin? You're not producing insulin, right? What happened? Glucose will not enter. So the cells will say, okay, so no insulin, so glucose will not enter. I can't take it. I have to find my alternative. What's alternative? I will use something else. I hate to do that, right? Like you don't have water, what should I do now? Just drink anything. Even if you have water that's remaining there for a month, just drink it. Do you have alternatives? Or you will die. So what should the cells do now? No insulin. The insulin is not pushing glucose in. I can't use glucose. What should I do now? I'm going to use an alternative. And that alternative is protein and fat. Is that something good? No, it's bad. This is not my primary source. I need glucose. I need to drink water, actual water. Don't give me anything and say just drink it. But do I have other alternative? I will die. So what should I do now? I'm going to use protein inside and fat. I'm going to use those as an alternative. And what's bad about this? The bad about this is if you use it as a source of energy, we do have a use for it anyway, but not as a source of energy. Or not as a primary source of energy. This is not why we have fat and protein inside. This is not the reason. Okay? Or instead of fat and protein, let's say amino acid and fatty acids. Okay? This is not the reason why we have it. We have it to build stuff, right? To make the wall, something like this. It's not as a source of energy. But the problem with having those as a source of energy is, if you break it down, you're going to end up producing an acid that's called keto acid. This is the end product. And this keto acid is bad because it's going to accumulate and you will go into acidity. Keto acid. Are we following so far? Did we get what does it mean? You don't have insulin, no insulin, glucose does not enter. We have to find an alternative. What's the alternative? No glucose. Use protein and fatty or amino acid and fatty acid. But the end product is keto acid. Keto acid is bad. It's an acid. It's bad. It's going to accumulate. You will enter into acidosis. And I will talk about this. Diabetic ketoacidosis, which is bad. But should I produce keto acid and you deal with it or die? No, I'll produce keto acid. Okay? So this is the primary problem that's happening if you cannot get glucose as a primary source of energy. Okay? So this is diabetes in general is inadequate insulin produced or inadequate receptors. So there are different types of diabetes. What does it mean? You mean you have enough insulin, but you're still diabetic? Yes. Because for insulin to work, insulin should go to the cells and tell them, let glucose in, right? In order to do that, you need to interact with receptors. You don't have receptors. So I'm insulin, I'm going to the cells. Where are the receptors? I want to tell them to get glucose in. No receptors. Useless, right? So there are different reasons. It's not just that you're not producing. So that will lead us to the different types of diabetes. We have type 1 diabetes and type 2 diabetes. Type 1 diabetes is the first one. You don't have insulin. This is the first type. You don't have insulin. This is type 1 diabetes. What happened to the insulin? Why you're not producing insulin? Where are we producing the insulin again? Pancreas. Which type of cell? Beta cells. What if the beta cells are destroyed? Autoimmune. We know autoimmune, right? Autoimmune against your own cells. For some reason, your immune system is getting crazy and produce antibodies against beta cells specifically. So you're going to break it down you end up not having insulin, right? Not having insulin. Is that the only reason? No, this is the most common one. And remember, it's always important to know the most common. Not just any reasons, the most common. So, type 1 does have an acute onset. So, once your beta cells is destroyed, glucose goes up. It's an acute onset. You have to remember this, acute onset. It goes all of a sudden. And it is usually children or adolescents. This is the time of start. I'm talking about the time of start. So if you tell me that I have type 1 diabetes, I'm not a child. Yes, I'm saying where did it start? When did it start, okay? Did you have it since you were a child, or did you start it right now? Did you get the difference? So yes, you're not a child and you have type 1. How comes? Yes, when did you have it? I have it when I was a child. Okay, that's what it is. Okay, so children or adolescents, and it have nothing to do with obesity. Type 2 will do. Okay, sometimes genetic factor will play a role in this, but this is what we need to know about type 1. Did you get type 1? Okay, type 2. Type 2 is not insulin dependent. It's not about insulin. It's not, the beta cells are not destroyed. You're either not producing enough, so are you producing insulin still? Yes, but not enough. Not enough. This is one, either not enough insulin, or you're having resistance to insulin, like receptors are not responding, right? Right? Or you're producing anti-insulin a lot. So anything that's not destroying beta cells, you call it type 2. And this is something that's happened in adults. So they call it the maturity onset. Okay? You're mature and you get this. Are we following so far? Type 1, children, adolescents. Type 2 is adult, maturity onset. This is type 2. It's not because of destruction of the beta cells. Beta cells are intact. This is not the issue. For some other reason, you're either not producing enough or you have resistance. Did you understand this? You have resistance somehow to insulin. Do you have it? I do. I have it. But I have resistance to it. So when does it start? Later on. 40s, 50s. It's not children or adolescents. It is associated with obesity. Why? Why is it associated with? Why obese people are more vulnerable to get type 2? Because in obesity, there is a disruption of the hormonal system and the receptors. They find an association between receptors not responding and obesity. Okay? For in obese people, there is more chance for your receptors, insulin receptors, to stop responding. It's not responding as it used to be. Did you get the association? This have nothing to do with type 1. You can be obese, you don't have type 1, right? Not obese, you have type 1, it doesn't matter. But obesity is linked to type 2. Type 2 is adults, maturity, obesity, adults, obesity, okay? So the type 1, you don't produce insulin, I give you insulin, right? And this is, we know people get insulin subcutaneous, right? They take insulin, this is type 1. You don't have insulin, I give you insulin. This, it's not about you don't have insulin. It's either you're not producing enough or you have resistance. How to solve this problem? I'll give you oral hypoglycemic medications. These medications will stimulate the pancreas to produce a little bit more. Stimulate the pancreas. So the pancreas is there? Yes. Beta cells are there? Yes. Producing insulin? Yes. Not enough. So I'll give you a medication to stimulate to produce a little bit more. All right? This is for oral hypoglycemic medications, and they also, some of them will increase the sensitivity of the receptors. Are we okay so far? All right. There is something called the metabolic syndrome, and the metabolic syndrome is five things, but you need to have 3 at least of those. 3, 4, 5 is okay, but at least 3. If you have 3 combined, I will say that you have metabolic syndrome. What are these 5 that you have to have? 4 of them. Central obesity. Central means in the abdomen, like not your whole body, just this part. So you will look like this. Okay? Central obesity. You have to have 3 at least. This is 1. Number one, you will have hypertension. You will have hyperglycemia. You will have hyperlipidemia. You will have low HDL. Any three of those combined, you have metabolic syndrome. Is that clear? What are the general manifestations of diabetic? This person is having diabetes, generally speaking. In both cases, remember, type 1 or type 2, in both cases, glucose goes up, right? It goes up anyway, whatever the reason is. Glucose goes up. Why it goes up? Because it does not enter to the cells. It accumulates in the blood. Make sense? Right? So glucose go up. Okay? Understand this. Do not just memorize it. Understand. First thing is, whatever the reason is, glucose does not enter inside the cells. It starts to accumulate in the blood, right? What else is going to happen? So this is the first criteria, hyperglycemia, isn't it? Hyperglycemia. Hyper, a lot. Glyce, glucose. Emia, blood. Increased level of glucose, and this is the first criteria. What will follow that? What will follow that is the blood will go to the kidney, and the kidney will find a lot of glucose. So it will get rid of it. It will get rid of it where? In the urine, right? You start to show glucose in the urine, and you call this glucosuria. Glucoseuria. Are we following? It's step by step. Just understand it one after one, okay? With this sequence. Glucose is not entering the cell, accumulating in the blood, hyperglycemia. You start to get rid of it, it goes to the kidney. Start to get rid of it in the kidney. What do you call this? Glucosuria. Are we following? Glucosuria. What's after glucosuria? Here's what's happening. Glucose goes to the urine, right? By osmosis, do you remember osmosis? By osmosis, some more water will follow through. So you will have more urine, and you call this polyuria. Are we following? Polyuria. Sequence, 1, 2, 3, 4, 5. Each one depend on the first, second, third, and so on. So what will happen if you have glucosuria? By osmosis, water will follow. Water will follow. So you make more urine, and you call this polyuria. Poly means a lot. Urea is urine, a lot of urine. And that explains. Do you know how many times you can go to the bathroom at night time, you're sleeping? How many times that you go to the bathroom and you're considered okay? How many times? 1? Nothing? 2? 0 to 2. If you don't go to the bathroom, that's fine. You go once. You wake up in the night time, go to the bathroom, once is okay, 2 is the maximum. More than that, you have a problem. I will tell you. You either have hyperglycemia, which is this, or something else. Maybe you're taking a lot of alcohol, diuretics, a lot of tea, but there are other reasons. But it's not considered normal anymore. You call it polyuria, right? So now I said that water will follow. You get rid of it in the urine, right? Dehydration, you're losing your water. Isn't that dehydration? Dehydration, right? So dehydration is the next one, right? So what after dehydration? If you have dehydration, do you want to drink? Right? You will become thirsty. So thirsty is the next one. Thirsty is the next one. You call it polydipsia. 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 A lot of thirsty. Polydipsia. Okay? You will be thirsty. You drink a lot of water to compensate for the dehydration. Right? Polydipsia. What else? Remember that I said that you're going to break down your protein and fat? Polyphagia. You eat more. Right? You're losing your protein and fat. You need to eat. You will feel that you're hungry. So sometimes you call this the disease of polys, to remember it. Polyuria, polydipsia, polyphagia, poly, plus dehydration and other things. Are we good so far? Did you get the sequence? If you remember the same sequence I'm saying right now, from the start point that glucose is not entering, and everything that will follow, you will understand or remember the manifestations. So now I know that you have diabetes. You have polydipsia, I go to the bathroom 4 or 5 times at night time, I feel thirsty all the time, I drink a lot of water, I feel hungry, and all that stuff. I'm suspecting that you have diabetes. What should I do now? There are different ways to estimate. In all cases, what you need to do is hyperglycemia. Do you have high blood glucose or not? All right? This is what you need to know. You might have diabetes, yes. Let me see how much glucose you have in your blood. All right? Fasting blood sugar is number 1, and you need to remember these numbers. You should be from somewhere from 70 to 99. Any one of those after fasting 8 to 10 hours, it should be something like this. Okay? If it exceeded that, I still don't say that you're diabetic. Okay? I don't. My blood glucose fasting is 110. I can't say diabetes. I say pre-diabetes. It's not a disease. You are going to develop. You are in the process of. Okay? So 100 to 125 is pre-diabetes. If it exceeded 125, meaning 126 and up, now you're officially diabetic. Okay? But you have to do it in 2 consecutive times, just in case if there is an abnormality or something happened or something, I have to measure it twice. So you're coming to me, your blood glucose is 130. Does that mean I'm diabetic? Most likely, come next week. I'll do it again. So you have to do it twice to confirm that you have diabetes. The other one is glucose tolerance test. Okay? Glucose tolerance test is, I give you an infusion of glucose, I give you a lot of glucose, and see how you're going to handle it. If your insulin is good, if your receptors are good, meaning you're not diabetic, you will take it, right? You will remove it out. If not, it will accumulate, you will not tolerate glucose, and this is glucose tolerance test. Is that okay so far? I'll give you some glucose and see how you're going to tolerate. The other thing is glycosylated hemoglobin. Glycosylated hemoglobin. What's glycosylated hemoglobin? Glycosylated hemoglobin is something for long term. Let's say the following, right? I measured your blood glucose right now and it is okay. It's okay right now. Does that mean that you're not diabetic? Not necessarily. Okay? So in order to estimate the long-term increased glucose, there is something called glycosylated hemoglobin. I'll get a sample of your hemoglobin and I'm going to test for glucose. Here is one thing that's unique about hemoglobin. What's the lifetime of the red blood cells? 120 days? Yes. Here is what's unique about the hemoglobin. They take the glucose, they keep it for lifetime. They take it and keep it. Okay? Take glucose and keep it for 120 days. So I'm going to get some hemoglobin sample and see how much glucose is kept in there. If it is high, the percentage is high, this is for long term. So you're telling me, let's say it like this, you're diabetic. Okay, how much diabetes, or what's the blood sugar? It's 130. I don't need medication. Can you try something else with me? Yes, okay, I'm gonna try the diet. Okay? Diet, don't eat much glucose and sugar and stuff, and I want you to exercise a little bit, all right? And let's see what's going to happen. Okay, I exercised, I did everything, and I think I'm fine. Let's see the glucose in a hemoglobin, glycosylated hemoglobin. And I can tell you if you're doing good or not, for long term, not right now. Maybe at this second you're fine, but I don't know what happened. Let's do, like example, I'm coming to you now. Can you see if I'm okay or not? I take a blood sample, yes, you're okay. No, that's not enough. Maybe you were fasting today, right? Maybe you exercised a lot yesterday. How do I know, right? So in order to estimate the long term, you have to measure glycosylated hemoglobin, and you need to remember that 7%. Okay?
Is that the A1C?
Yes. Yeah, HA1C. So it should be 7%. If it goes more than that, I will tell you, you're not adjusted. It's not okay. It's not good. Even if blood glucose at this moment is okay, right? Maybe last week it was not okay. So it monitored for several months. So what's the goal of treatment? Just simply, the goal is to keep blood glucose within the normal range. What's the normal range again? 70 to 99. How about hundreds, 105? Do you consider that diabetes? Pre-diabetes, great. Okay, very good. So I want it to be within the normal range. Okay? If it is increasing a little bit, meaning if you are pre-diabetic or you are diabetic but just a little bit, let's say 130, it's not 200, it's not 190, 130. Is it diabetic? Are you diabetic? You are. As long as you are 126 or more, you are diabetic. But if that's the case, I don't have to rush into medication. And I can try the diet and exercise, right? I will tell you, I want you to reduce your sugar intake, I want you to exercise a little bit, and so on. I will measure your glycosylated hemoglobin anyway. And it should be within 70 to 99. And what's glycosylated hemoglobin? 7%. 7%, up to 7% is fine. So, if that's the case, I will get rid of the extra glucose and you will be fine. If that didn't work for some reason, I will start to give you 1 out of 2, depend on the condition. If you're type 1, what should I give you? Insulin. If you're type 2, what should I give you? Oral hypoglycemics in general. This is one of them. Oral hypoglycemics in general. So it depends on the situation. It depends on the diagnosis. Are you type 1 or are you type 2? Now look at this. Remember we talked about this? What if you cannot use glucose? What are you going to use? Fat and proteins. And what's the dangerous about this? Keto acids. Keto acids. So what will happen if you cannot use your glucose? You are going to catabolize fats and proteins. You end up having keto acid, right? And you call this ketonemia, ketonuria. What's ketonemia? Ketonemia. High ketone. What's ketone? This. Keto acid. Okay? What's ketonuria? Ketonuria. Same in the urine, right? So it's going to accumulate, start to increase in the blood, and then it's going to start to show up in the urine. And what did we say again? What is this? Keto what? Acid. So it's an acid? An acid, right? An acid. So pH goes up or down?
Down.
Up or down? Pick one.
Down.
Down. It's always the opposite of what you're thinking. I know you're thinking hydrogen goes up, pH goes up. It's the opposite. Okay? There is a calculation that's not important now. It's minus log the hydrogen ion concentration. This is not the issue. Just remember that pH goes down, acidity. So the pH will go down in this case, right? And you call this metabolic acidosis, specifically. Metabolic acidosis. Do you remember the types of acidosis? Means pH goes down in general, right? Depending on the cause. It can be respiratory, metabolic. I think we talked about this before. You guys remember? Acidosis means pH goes down. What's the reason for pH to go down? 2 reasons. It's either coming from the respiratory system or something else. Whatever that something else is, you call it metabolic. All right? Respiratory like what? Like this. I'm not breathing much. Stop breathing. Slow down your breathing. Or you're sick. You can't breathe much. If you're not breathing much, you don't get rid of carbon dioxide, right? Carbon dioxide accumulate. React with what? When the carbon dioxide, remember the carbonated beverages? Carbon dioxide react with what? Water, making what? What do you call the beverages? The Pepsi? Carbonated. So what's produced? Carbonic acid. Carbonic acid. So this is called respiratory. In this case, it's not respiratory, so we call it metabolic acidosis. This is one of the problems. And remember that this is type 1. We're talking about type 1 so far. Complications. Complications will depend on the extent and which type. Is it type 1 or type 2 diabetes? And the complications can be acute or chronic. What does it mean? Acute, something that happened fast, all of a sudden. Chronic is something that takes time, right? Acute. Acute is something that happened all of a sudden. Okay? You were okay now. Afternoon, Nighttime, you're not okay anymore. Acute. Okay? Number one is hypoglycemia or something called insulin shock. Insulin shock. So let's say you're diabetic. Let's say your blood sugar is 150 and you're taking insulin, right? You're taking insulin to reduce blood sugar to become normal, not under normal, right? This is not the goal. The goal is not to go down as much as possible. That's not right. Right? Physiology is all about normal. So you need it to go down in between 70 and 99. What if it goes under that? Is that good or bad?
Bad.
That's bad, of course. And what do you call this? Hypoglycemia. Hypoglycemia. Hypo, low. Glyce, glucose. Emia means blood. Hypoglycemia. That's something bad, of course. What is the reason for somebody diabetic, which have high sugar, high blood glucose, what make it go under normal? Insulin shock. What's insulin shock? There are a lot of reasons, but the most important and the most common, and I want you always to remember this, okay? It's not just 5, 10 reasons. What's the most common? The most common is strenuous exercise. So you're coming to me, I feel dizzy, I feel disoriented, I cannot concentrate, I feel like I'm going to drop, I don't know what's happening, there is something wrong happening, I measure blood sugar and it is under normal. Let's say it's 60 or 50 or something, okay? I'll ask you some questions and according to that, I will know exactly what happened. But the most common is, did you exercise a lot? Oh yeah, yesterday I was running for 2 hours or I used the treadmill a lot. Right? Strenuous exercise. So, because the dose of insulin is adjusted according to what you're telling me, right? So I ask you, what's your exercise level? I just do like a little bit of workout, like 15 minutes or something. What you eat, what you do this and that, and I adjust the dose according to your needs, according to your lifestyle, right? So if you do strenuous exercise, all of a sudden, and you're taking insulin, you're using a lot of sugar, it will drop, and this is the most common cause. What else can happen, or what else can be the reason for that? Maybe I know that you're taking insulin, but you're telling me, I eat 3 times a day, right? I'm adjusting the dose according to that, okay? You skip the meal. Blood glucose, instead of just going down to normal, it will go under the normal, right? What else can happen? Anything that puts some stress on the body, something like infection. I don't know that you get infection. If you have infection, you need to fight, right? And you need more glucose, you will use it. So a drop under normal. How about this? Abnormal dose, or less than normal. You didn't know, you take a lot. I'm telling you, you have to take like 5 millimeter. I taught you how to do it, take 5. And you okay, 5, you got 10. Error dose, okay? In all cases, you will get hypoglycemia or insulin shock anyway. But what's the most common reason?
Exercise.
Strenuous exercise. If you're exercising a little bit, you're still okay. Strenuous exercise. This is the most common one. So here it is. Insulin is a lot for some reason. Hypoglycemia. Because of the hypoglycemia, glucose is not enough in the body and the body will start to react. Okay? What's a reaction? Let me give you just a little bit. It's not much. This is pathophysiology. But just a little bit of biochemistry. A little bit. Okay? When you eat, you take glucose and you're going to store that glucose in your liver in the form of glycogen. Okay? You store the glucose in the form of glycogen. What's a glycogen? Glucose plus glucose plus glucose. It's a huge chain of glucose. This is how we store it, right? So if I need it, I'm going to break down glycogen and take glucose out of it, right? This is one way. The other way is there is something called gluconeogenesis. I'm not going to go to the details. It's not biochemistry. But just understand this. Gluconeogenesis. Let's break it down into pieces and always do that. Gluconeogenesis. Gluco means glucose. Neo means new. Genesis means generating. So you generate glucose from a new source. What does it mean? Meaning I get the fatty acid and convert it into glucose. I take the amino acid and convert it into glucose. Can you do that? Yes, your body can do that. Did you get the gluconeogenesis? Do you understand this part? Gluconeogenesis, did we get this? Okay, so you'll start to do some gluconeogenesis just to compensate a little bit, but by the time you do that, there is not enough glucose in your system. So your brain, inside your brain, you'll start to have some disorientation. You don't have enough glucose, you become disoriented, you become stressed out, you don't have enough glucose for your brain, cerebral function drops, right? If it is too low and continuous, you're trying to work on it. You're trying to do gluconeogenesis, right? You're trying to get some more glucose. You're trying to do glycogenolysis. You break down the glucose. You're utilizing your sources, not enough. Not enough. It's too low. You need to compensate right away. If you do not compensate for a long time, you will become disoriented, you become dizzy. This is just at the beginning. If you continue and you don't stop it, it can go to coma. So this is the severe part of hypoglycemia. Are we following so far? Okay, hypoglycemia. If it is severe, prolonged hypoglycemia, it can lead to coma. The brain does not have a glucose source. The brain cannot eat. Okay? So hypoglycemic shock is a shock. When you hear shock, what shock means? Shock. Severe depression or severe decrease of the blood pressure. Shock. Blood pressure goes down. Okay? Until it goes to shock. Or our glucose goes down until you go to shock. What's a shock? You become disoriented, and I mentioned that. You become anxious. Your blood glucose goes down, and look at this. What is this? Blood pressure. Shock. Blood pressure shock, right? Blood pressure will drop because of that. Of course, heart rate will try to compensate for that. So it's all about, if you think about all of this, just put them together. Most importantly is the brain is not getting enough. If your brain is not getting enough, you become anxious. You become disoriented. Your level of consciousness goes down, right? Glucose level goes down, blood pressure goes down, and so on. How to treat that? It depends. Are you conscious or not? If you are conscious, I will tell you right away. Drink something right now. Get some juice, some sweet, something that have a glucose source. If you're not, I will rush you to the hospital and I will give you an IV dose of glucose about 50%. Okay? So if you have hypoglycemia, what should I do with you? It depends on, are you conscious? It means it's not severe, right? If you're conscious, it's not severe. So what should I do now? Drink some juice. Get some candy. Get something that have glucose, right? If you're conscious, it's not severe enough. If you're unconscious, it's severe enough. Rush to the hospital, IV concentrated glucose. Yes?
Is that what makes, when you are hypoglycemic, is that what makes you crave the ice?
For hypoglycemia, it's more for diabetic ketoacidosis that I'm going to talk about. That you need something to increase the water intake, thirsty. The next one is diabetic ketoacidosis. What does it mean? Diabetic means you have diabetes, right? Ketoacidosis. Ketoacidosis. You have a lot of ketoacids, which is this. Right? So diabetic ketoacidosis. This condition is more in type 1. You have to know this. 2 conditions so far. Are we following? Hypoglycemia or insulin shock and diabetic ketoacidosis. These are acute complications of which type? Type 1 specifically. Type 1. Type 2 will have its own complications, but this is for type 1. So it's more commonly in type 1. Okay? And we already talked about it here. Okay? What happened? What happened is there is a problem with insulin. I don't have insulin. I cannot use glucose. I use fatty acid. I use fat and proteins as a source of energy. You end up having ketoacidosis, right? A lot of ketoacidosis. Ketonemia and keto what? Ketonemia and ketonuria. Yes, ketonemia and ketonuria. Usually this condition will be initiated by some sort of stress, like infection. You have a lot of stress or you have infection. One of these, and understand why. Why? Because I need a source of energy. You're not giving me glucose. I'm going to use fat or amino acid or proteins, right? But you have infection, which is even worse. So I need a lot of it. So produce more keto acids, diabetic ketoacidosis. Did we understand why specifically, why it happened more after infection or stress? Did we get this point? Is that clear? Okay, so it's more after infection and stress because of more needs of the cells for a source of energy. Okay? Sometimes it's an error in the dosage or alcohol or something, but this is the most common reason. You start to use fatty acid and keto acid. Did you use glucose? Did you use glucose?
No.
You can't use glucose. You don't have insulin, right? You didn't use glucose. So glucose accumulate, and what do you call this? High glucose in the blood? Hyperglycemia. Hyperglycemia, right? So diabetic ketoacidosis, you have hyperglycemia, high glucose, high keto acid. This is the bottom line. High glucose, high keto acid, diabetic ketoacidosis. And this is one of the acute complications of type 1 diabetes mellitus. And what we said again, this is keto what? Keto acidosis? Acidosis, right? So diabetic ketoacidosis, there will be acidosis. pH goes down, right? So this schema is describing what we talked about. Glucose is not transported to the cells anymore, accumulate in the blood. You will have polyphagia. Do you remember the polys, the 3 polys that we talked about? So you start to use other sources, lipogenesis, you get the keto acids. You start to have hyperglycemia, it starts to appear in the blood, followed by osmotic diuresis, followed by what happens when you lose a lot of urine? You get dehydrated. You get dehydrated, right? So dehydration is the ultimate, and you get polydipsia, which is thirsty, and you need to understand the meaning of each one of those, okay? Polyuria, polydipsia, polyphagia. What's polyuria? A lot of? Urine. What's polydipsia? Thirsty. What's polyphagia? Hunger. Okay? You're hungry, you're thirsty, and you make a lot of urine. And you have some acidosis, and because of the acidosis, you will have also electrolyte imbalance. Electrolyte imbalance. You'll get some electrolyte imbalance. And this is actually one of the reasons for disorientation. You will be disoriented. You have electrolyte imbalance. What's the relationship? Why? Here's why. Potassium and sodium specifically are linked to the pH. Potassium and sodium specifically are linked to the pH. Okay? Because potassium is linked with hydrogen. Sodium is linked with bicarb. So if you have disruption of that, you have a lot of acid, you will have a lot of potassium. Did we understand this? Again, potassium is linked to hydrogen. Sodium is linked to bicarb. They are linked. They follow each other. So if hydrogen increase, you will get a lot of potassium and low sodium. Isn't that disruption of the electrolytes? Electrolyte imbalance. So we have this orientation because of that. I think we will do some practice at the end. We have enough time to do that at the end, just to exercise and to confirm our information. So we said in the diabetic ketoacidosis we have dehydration, right? You have dehydration, we talked about this. You have ketoacidosis, metabolic acidosis, and electrolyte imbalance. We covered all of this. How about breathing? This is one more thing to add. Did you get the sequence one after one after one? Right? Glucose does not enter, hyperglycemia, go to the urine, glucosuria, followed by water, polyuria, dehydrated, thirsty. Polydipsia. You get hungry because you're breaking down your proteins. Polyphagia. Do we get all of this? Okay. And obviously, you'll get acidosis. pH will be disrupted, which is metabolic acidosis. Electrolyte imbalance, and electrolyte imbalance will cause a lot of problems. One of them is disorientation, and the others are body cramps, muscle cramps, and so on. Now, the only thing that I'm going to add, we got everything so far. Are we following? Okay, the only thing that I'm going to add is the respiratory pattern. The respiratory pattern. What's the respiration of this patient if he's diabetic ketoacidosis, or actually if he has coma? You know what? In the hospital, once we open the door, I can tell right away from the odor. Just opening the door, this is diabetic ketoacidotic coma. Right away. Why? Because of this unique odor. Fruity acetone breath. You enter the room, I feel this breath immediately. Even if I don't know anything about the patient. I get in, acetone odor, fruity odor. Does this patient have diabetic ketoacidosis? Are you diabetic? Yes. So expect diabetic ketoacidosis, and his respiration will be rapid and deep. It goes like, so you go to the room, you see the patient, and you smell, that's it. This is diabetic ketoacidosis, even if he's in coma. You can't ask him. Just by smelling and seeing the respiratory pattern, you can tell. The other respiratory pattern, or this pattern, is called also cosmal respiration, and you need to know the name specifically. If you don't have it, write it down. Cosmos respiration. Cosmos. Which is this. Okay? Are we following so far? Now, maybe ask yourself why. Why I'm breathing like this. Remember that you have ketoacidosis, right? Your pH is going down. If you do that, if you do the cosmal respiration, you breathe too deep and too fast, you get rid of a lot of carbon dioxide, so your acid go down in another way, which is called compensation. So here is a point. Here's a point. We said metabolic acidosis. Is that true? Compensated or decompensated? What does that mean? Compensated or decompensated? This way it will be compensated. What do you mean compensated? Keto acid goes up. This is acidosis, isn't it? pH goes down, right? Now the body will say, okay, what should I do now? The acidity is really bad. It will lead to electrolyte imbalance. This is bad, right? What should I do now? Can I get rid of the keto acid? Takes long time. What should I do now? Now. If you breathe faster and deeper, you kick out a lot of carbon dioxide. Carbon dioxide does not react with water, so you don't have carbonic acid anymore. Your acidity goes down. Isn't that good? Compensation? So what do you call this? Compensated what? Compensated acidosis. Compensated acidosis. So if I ask you, is the metabolic acidosis compensated or decompensated? This way it's compensated. Did we get this point? It is what compensated means. Meaning it's acidic, but you reduce it a little bit through the respiratory compensation. So this is just wrapping up all what we talked about, just repeating everything again. Take a look at this table. It's good to summarize all what we talked about, but it's repeating the same thing that I mentioned a couple of times, okay? So it will be glucosuria, hyperglycemia, glucosuria, and all these sequences. So the next part will be, how about the type 2? How many complications did we mention so far to type 1? Two, right? We said insulin shock or hypoglycemia, and we said diabetic ketoacidosis. How about type 2? Does he get any complications, acute complications? Yes, he does have the HHNK. HHNK. It's hyperglycemic, hyperosmolar, non-ketotic. Non-ketotic. No ketoacidosis. It's a different situation. And this is in type 2. Remember that in diabetic ketoacidosis is an acute condition. It goes up fast. In this one, it's insidious, meaning it is gradual, right? So let's read it again. Hyperglycemic, hyperosmolar, non-ketotic. By the way, if you just read the name, you can tell most of the manifestations that are happening here. Hyper means Above or high. Glyce, sugar or glucose. Emic, blood. So what does it mean? Hyperglycemic, high glucose in the blood, right? So when I ask you what's HH and K, you say hyperglycemia is number one. Number two, hyperosmolar. Hyper means high, osmolar means osmosis, which is osmolarity. The osmolarity goes up, right? The osmolarity, do you remember the osmolarity? Like when it goes to the urine, it will be followed by water. Osmolarity, hyperosmolar. And what non-ketotic means? No ketoacidosis. No ketoacidosis. And this is in type 1 or type 2?
Type 2.
Type 2. And the problem with this is it can go undiagnosed because it's gradual. It's insidious, gradual. You go bit by bit. You don't feel it much. The other one, dramatically, all of a sudden, shoots up. Okay? Cognitive condition deteriorate fast. So you can tell. In this one, you cannot tell right away, but in all cases you have hyperosmolarity, okay, and then you will have dehydration and electrolyte imbalance. So what do you have here from the name? HHNK. Do you have ketoacidosis?
No.
No. Do you have hyperglycemia? Followed by glucosuria? Followed by dehydration? Followed by electrolyte imbalance? Is that all clear? This is just follow each other. And you have hyperosmolarity. So you got most of it already. Hyperglycemia, severe dehydration, electrolyte imbalance, that will make the muscles weaker, that will make you disoriented because of the electrolyte imbalance and so on. For severe dehydration, how to know that this person is dehydrated? Did you see somebody dehydrated before?
Yeah.
Do you know how they look like? What happened to the skin? What is it? Yes, so the skin will be lax, dewy, lax, right? Like you fold it like this, it goes down slowly. The eye will be sinking, right? If you see somebody who's dehydrated before, lost a turgor, the heart rate will go up, tachycardia, hematocrit will increase because of concentration of the blood, and so on. So you will see signs of dehydration and electrolyte imbalance. Now the chronic complications. Chronic complications is all about blood vessels. Are we following so far? Did you get the 3 acute? 2 in type 1 and 1 in type 2? Okay, now what's a chronic? What chronic means? Means you have diabetes and you're not doing anything for a couple of years, let's say. Okay? Did you check? Were you checked before for glucose? No. So you don't know you're diabetic? No, I didn't know. Okay? So this is something chronic that takes time. And we're going to divide it as follows. Remember that chronic is all vascular. It's all about blood vessels, right? The only difference is what type of blood vessels are we talking about? Large blood vessels or small blood vessels, right? Large, you call it macro. Macro means? Large. Macroangiopathy. Macro means large. Angio means? Vessel. Pathy. Disease. Disease of the big vessels. Make sense? How about microangiopathy? Disease of the small vessels. What are the small vessels? What's the smallest vessels you know? Arterioles and? Capillaries, yes. So when we say macro, we're talking about the big vessels, right? Arteries, big arteries, mid-sized arteries, small arteries. When we say micro, it's more toward the arterioles and the capillaries, which is this, okay? So what will happen in microangiopathy, microangiopathy, pathology of the small vessels. Small vessels are feeding the neurons. Remember that the nerve, the neurons, the nerves itself, it has to get some blood itself, right? Small vessels feed the neurons. Small vessels go to your retina. Small vessels are inside your kidney. All of this will be diseased. What disease means? Here is the most important thing. What exactly happened to the blood vessels? Exactly. Atherosclerosis. What's athero means? Sclerosis means black. Athero. It's a prefix that means fat. So atherosclerosis is accumulation of fat. Atherosclerosis. Blood sugar increase, affecting this, start to accumulate, making it tough, make the blood vessel wall tough, fibrotic, and because of that, the fat will start to accumulate. Did you understand this? Because of the high blood sugar. So by the time this will become smaller, narrower, less blood supply will go to those three neurons, retina, and kidney. Okay? So this will lead to neuropathy, retinopathy, and renal failure. Neuropathy, what's neuropathy means? Neuro means neuron, pathy, pathology or disease. So disease of the neuron, diseases of the retina, it can actually lead all the way to blindness. Maybe this person will become blind later on. Okay? And chronic renal failure. Why is it chronic? Because it takes time, right? It takes a couple of years or maybe more. This is summarizing the macro and micro. So this is good enough to know regarding the chronic complications. So micro, we talked about this. What are the organs? Nervous system, eye, and kidney, right? Small blood vessels in those three. Are we okay so far? We following? Okay, so microangiopathy, kidney, eye, nervous system. Don't forget this. Kidney, eye, nervous system, right? What happened to the kidney? Diabetic nephropathy that can lead to chronic renal failure. Diabetic nephropathy. What's nephro means? Kidney. So it's a disease of kidney because of diabetes, right? It can lead to chronic renal failure. Goes without saying, let's just say this and apply it for all complications, all of this. Here. Blood vessels. Sugar is a lot. Accumulate. Fibrosis. Rough surface. Right? Fat accumulate. Atherosclerosis. Sometimes aneurysm, if it is too weak. Okay, apply this in anything. A problem happened with the blood vessels because of this. Atherosclerosis, sometimes aneurysm. And this will affect the organs. So diabetic nephropathy, retinopathy, the retina will be affected because obviously the retina is getting blood supply from small or micro blood vessels, and the nervous system will be affected, neuropathy. Okay? Which function will be affected in the nervous system? What are the functions that we know? You have sensory and motor, right? So sensory, you lose the sensation, right? So if you know somebody who's having diabetes for a long time, they will say that I don't feel my feet, right? Did you hear this before? If you touch the feet, I didn't even feel it. This is a sensory deficit. Motor is later. So I had diabetes for 5 years, and now I'm having a problem like moving my upper limb, moving my legs. So this takes more time. But the first one that was going to appear is neuropathy, to the extent of, believe it or not, to the extent of, those people can have ulcer in their foot and they never even know why. They hit their leg a lot, they never felt it. Something called diabetic ulcer. Okay? You do a lot of friction and you think about it. Wow, is it painful? No, it's not. I don't even feel it at all. Right? And sometimes you kick your feet a lot, you don't feel anything. No pain. Imagine no pain. The pain is actually protective, right? The pain is protective. When you have pain, you stop doing it. If you don't have pain, you continue, right? To the extent of ulcer, and you don't even feel it. Do you know that you have ulcer? No. Okay? How about the macroangiopathy? Macro is the big ones that are feeding heart, brain, peripheral vessels. You're welcome. Heart, brain, and peripheral vessals. Okay? Heart, it can lead to heart attack. Remember that, what is feeding the heart? Do you remember these arteries? Do you remember right coronary artery, left coronary artery? Do you guys remember this? Yes, these are big vessels. We're not talking about arterioles here, right? So this is macroangiopathy, so it can lead to myocardial infarction. What infarction means?
Heart attack.
Death, actual death of the heart tissues, right? Actual death. So myocardial infarction, which is heart attack. Cerebrovascular accident. Accident of the blood vessels to the cerebrum, which is the brain, right? And the third one is PVD. What's the PVD? Peripheral vascular disease. Most importantly here, the lower limb. The blood vessels in the lower limb, they get atherosclerosis, so the arteries become narrower and narrower and narrower to the extent of necrosis, yes, which is called, there is a name for it, gangrene. It can lead to gangrene. Gangrene is necrosis specifically due to low blood supply of the extremities. Okay, gangrene. So it can lead to gangrene. Ischemia that can lead to gangrene, which is the peripheral PVD or peripheral vascular disease. Ischemia and gangrene. And what do you think what they will do with the gangrene? Huh? Amputation? Yes. It's bad, but if you don't amputate, it will go up. You don't amputate, it will go up. You die. So lose one better than losing everything. You have a question?
Yeah, no, I know somebody who had he found out he had diabetes, but he had gangrene in his toe and they have to cut it off. He's fine.
They cut it off?
Yep.
Yes, but because this is protective, I mean it's bad, but should you keep it and it start to go up, it will not go away. Gangrene will never go away.
Diabetes though can cause gangrene.
Yes. Why? Because of the blood vessels to the lower limb getting narrower and narrower and narrower. Atherosclerosis, less blood vessel ischemia, it can die, which is called gangrene. Amputation. So if I ask you, why amputation happen with chronic diabetes? Atherosclerosis, narrowing of the PVDs, of the peripheral vessels, peripheral vascular disease. Did we get this? Okay. This is diabetic nephropathy. So I'm not going to do it again. This is repeating. Do it from the table, that's good enough. This is all what you need to know. This is just a picture of the diabetic foot that I talked about. Look at this. This person even didn't know. They have that bad ulcer. Why? They don't feel it. You don't feel it. One of the chronic complications is infection. Infection where? Anywhere. You get infection. Here is the key point. Do you know why diabetic people get more infection than other people? Why? Difficult to heal? Why? Yeah, this is right, but why? Immune system, kind of. This is one. This is one. Less blood is going there. What else? There's one more. The sugar is number one food for microbes. Right? They eat it. You have a lot of sugar, they will eat it. You know, why you get dental caries if you don't brush your teeth? Did you ever think about it? You know why? A lot of sugar. These bacteria, by the way, all of us have it. None of us don't have these type of bacteria, have the microbes in your teeth. You do have it. The difference is, these microbes are too weak. They are too weak. So they cannot invade your teeth. But give them the source, they will eat, flourish, they will invade you. This is simply what it is. If you think about it, why do I get dental caries? Don't all of us have the same type of microbe? Yes. But I'm feeding it, you're not feeding it, right? You brush your teeth, remove the sugar, they don't have enough source, they are weak. They cannot invade you. They cannot invade your teeth. Don't brush your teeth, don't clean it, a lot of sugar, a good source of nutrients, they eat it, they become super, they become strong, they attack your teeth, dental caries, right? Did you get this point? So this is the other reason. So we have two reasons for that. Multiple infections, and all of them is one out of those two. Either because you're providing an excellent medium for the microbes, or because of less blood supply. And this can affect a lot of things. Even fungi. Do you know that all of us have fungus in the mouth and in the vagina? Right? We all have fungus, right? But the fungus is very weak. It doesn't do anything. It's just live there and it's not harming you. It doesn't do anything. If you get a sample from anyone, you will have a fungus, that's for sure. But is it doing anything? No. Why? Too weak. It's too weak to do anything. Unless you feed them, right? You feed them. High blood sugar, you feed even the fungus, you start to get this fungal infection, and you see in the mouth or in the vagina, you see infections, white, candidiasis in the mouth or in the vagina or something. These two cavities specifically, they have a lot of fungi. Okay? You get it in the urinary tract, dental caries, and in this, did you see a picture of somebody who's not brushing his teeth for years? Do you see how even the gingiva is really bad? The gingiva itself is invaded. Look at this picture here. Okay. Go through. Okay, the other one is, how about the eye? We talked about diabetic retinopathy. We talked about this. Diabetic retinopathy, right? Is it macro or micro? You have to know this.
Wait, say it again.
Diabetic retinopathy. Is it micro? Micro. The blood vessels in your retina is too tiny. If it is big, you don't even see. Right? It's the small ones. You have to remember this. Which one is micro and which is macro? Macro is something like myocardium, heart, brain, peripheral blood vessels, big. Small is something like nephro, kidney, something like retinopathy, your eye, right? Neuropathy, neurons. Did you get this? Okay. So what's the cataract? Cataract is abnormal metabolism inside your lens. What's the color of your lens? Clear. The lens cannot be white or brown or anything. It's clear. You will not see. If any color, it doesn't have a color. Okay? Maybe you're an exception, but no, I'm just joking. It is colorless. Okay? Transparent. Otherwise, you don't see. If something happened to the lens, it's not transparent anymore. It will become white, and you call this cataract. Did we get this? Cataract. Not transparent anymore. Pregnancy. If this mother is having a diabetes, you call it gestational diabetes. If you don't have it, write it down. If you don't have this, if you're printing something, you don't have it, anything that I'm adding, I told you, I know exactly what's there. Okay? So write it down. You don't have it, write it down. Gestational diabetes. The diabetes of pregnancy diabetes. Okay? So this is, if this mom is pregnant and she have diabetes, you call it gestational diabetes, and both the mom and the fetus, both of them will be affected because the baby will take from the same blood, which have a lot of sugar, right? So what will happen? First of all, there will be a spontaneous abortion. They can abort really early. The baby is getting faster and is pushing on the uterus, so expelled faster. Or if this baby is okay and he's okay until the end, he will born with diabetes and the body size will be large. Delivery will be really hard. Okay?
That's if the sugar is not controlled, right?
If it is not controlled, exactly, yes. Which is diabetes, uncontrolled gestational diabetes. Okay, this baby, once he leaves his mom, he will have hypoglycemia. Because you cut the source of sugar and he returned back to normal, and he will act on the blood sugar to the extent of hypoglycemia. Okay? So these are the complications, just repeating everything that we talked about in the picture, so it will be easier for you to remember. There is a video here that's going through the complications.
With diabetes are at a higher risk of certain health problems. As a person with diabetes, it is important to monitor and maintain healthy blood glucose levels. High blood glucose levels over a long period of time can lead to heart attack and stroke, blindness, kidney failure, and nerve damage. Heart disease and stroke are 2 to 4 times more common in people with diabetes. High blood glucose levels increase the rate of plaque buildup in your artery walls. The plaque makes it difficult for blood to flow through your arteries and can even block it, causing a heart attack or stroke. A common eye problem in people with diabetes.
Controlling type 2 Simply, if it is marginal, just do exercise and diet. If it is not, you do hypoglycemic medications. Did you understand this? So in all cases, diabetes, try diet and exercise if it is not that high. Didn't work, medication. What type of medication? Type 1 is insulin, type 2 is oral hypoglycemic, and that's good enough. Of course, you will need to monitor your blood glucose level, routine checkup, and so on. Now, calcium level. The next, we finished, which is like half or more of this chapter, diabetes, the most important one. And the next one will be as follows. Calcium homeostasis. Can you tell me what are the two hormones that are working on calcium? Calcitonin. Thyroid hormone. Which one increase and which one decrease? Calcitonin? Decrease. Parathyroid? Increase. Don't ever forget this. It was in the table at the beginning, okay? Parathyroid increase, calcitonin decrease. How does the parathyroid increase? It's simple. More input, less output to increase the calcium, right? Like a sink. More in, less out. Simply. More in, where did you get it from? More absorption, more calcium coming from the bone. Do you know that you store your calcium in the bone? Extra calcium? You can take it from there? Yes. Two inputs, they increase them, and one output to decrease it. How about don't lose it in the urine? Right? It's exactly like this. Water tap, I wanted to keep this water in the sink the same. Control the in, control the out. What if you wanted to increase it? Increase in, less out. What's in? Where do you get calcium from? Two sources, absorption and mobilization from the bone. You take it from the bone. Take it from the digestive tract, you take it from the bone. Or don't lose it. Less drainage, right? Don't lose it in the urine. Do you lose it in the urine? Yes, you can. If you don't stop it, you will use it. You will lose it, right? So by doing this, parathyroid hormone is going to increase calcium level. How about calcitonin? It's the opposite. Now let me ask you this. When parathyroid hormone, for some reason, it takes a lot of calcium from the bone, what happened to the bone? Become weak, right? Become weak, which is osteoporosis or osteomalacia, right? Or osteopenia in general. Weak bone, it will become weak, but that's okay. I mean, if you don't have enough calcium in your blood and you take it from the bone, your bone become weak, okay, better than dying, right? What do you need the calcium for? I need it for the following. Muscles. You cannot contract your muscles. Your heart cannot contract, you will die without calcium. I will take it from the bone and I don't care about the bone much. Even it will become weaker, better than dying. You cannot contract your muscles without calcium. Your nervous system will not work without calcium, simply. You cannot work without calcium. Okay? So it's okay. I'm going to take it from the bone. Parathyroid hormone, take it from the bone. It will become weak, that's fine. Okay? What happened with immobility? Why? If you are in the hospital, they tell you you have to go around a little bit, you have to walk a little bit. You cannot lay down and not do anything. You have to. Why? Because immobilization, simply your bone will, the rule of the thumb is use it or lose it. Use it or lose it, right? So if your bone, if you're not moving around, your bone will say, okay, probably he don't need the bone anymore. He's not moving anyway. So why don't I take the calcium and give it to the rest of the body to use, right? So that will become, the bone will become really weak. Calcium level the calcium level actually will go up, but the bone will become weak. Hypercalcemia. So immobilization leads to hyperglycemia. Hyperglycemia. Hypercalcemia. Did you understand this? You're not mobilizing. Your bone thinks that you don't need it anymore. You don't need a strong bone. I will take the calcium, throw it in the blood. Hypercalcemia. Immobilization, hypercalcemia. How about if you have a problem with your kidney? Your kidney is supposed to save your calcium. You have a kidney problem. You lose calcium. Calcium goes down. Diseases from now on will go high and low. Hypothyroidism versus hyperthyroidism. Hypopara versus hyperpara. Hypoparathyroidism. It leads to high calcium or low calcium? Low calcium, so hypocalcemia. And what if you have, I told you the rule, okay? Apply it. Calcium is needed for nerves and muscles. Simply. Nerve and muscle. Nerve and muscle. I don't have calcium. You have a problem with your nerves, you have a problem with your muscles. Is that simple? It is simple, okay? You have a problem with the muscles and the nerves. So we'll have problems with these. What's the reason? Anything. Remove that. We talked about this before, remember? So we don't have to repeat. Why do you have a problem? Less secretion with parathyroid hormone, surgical removal, autoimmunity, accidentally removed, anything, congenital, anything. It's the same reasons, by the way, you're going to repeat it over and over again. You remember when I told you, generally speaking, the most important factor, the most common for hypersecretion is benign tumors? It's the same for everything. How about hyperparathyroidism? Hypercalcemia. What if you have a lot of calcium? It's the opposite. How about it? What will happen? You have, it can be caused by tumors or renal failure or paraneoplastic syndrome. Does anybody remember the paraneoplastic syndrome? Neoplasia means cancer, tumor. You have a cancer, and the cancer, for some unknown reason, start to release its own factor that resembles parathyroid. So this is hypercalcemia. And where do you get the calcium from? From the bone, osteoporosis. Did you link the whole thing together? Where do you take it from and where do you put it, right? You take it from the bone become weaker. You put it in the muscles will become stronger. Stronger means bad. The heart will contract more than it needed, which is not good. Hyperthyroidism. And here are the problems that will happen if you have hypo versus hyper. Hypo, you will have the nervous system will increase neuroexcitability, tingling, skeletal muscles will have a spasmodicity, the heart will become weak, and the digestive tract will have more peristalsis. Hypercalcemia. Thank you. Hyper, increased neuroexcitability. Okay? You have apathy and fatigue. Muscle will become weak. Kidney will have polyuria. You might have calculus. Peristalsis now decrease because of low calcium. And the bone will become osteoporotic. Pituitary gland. The most common problem with the pituitary gland is adenoma. Adenoma. And what's bad about adenoma in the pituitary gland? Do you guys remember the skull? Did we do the skull? Do you remember the sella turcica inside? Did you do the skull? The sella turcica, this is where the pituitary gland is located, which is right under the brain. So if this pituitary gland have a tumor, it will start to push on the surrounding. And the surrounding is the optic chiasm. Does anybody remember the optic chiasm? Optic chiasm. If you press on the optic chiasm, one of the eyes will become bad, and you call this hemianopia. I am not saying anything that's not important. I'm not wasting the time. Hemianopia is something specific. Hemianopia, like this is a crossing, right? If you push it in the middle, one side of the eye will lose the function. The pituitary gland is right in the middle of the crossing. So if you push it here, half of the eye, hemianopia. What else? You can push, irritate the brain. You can have seizure, visual defects, depending on the problem. And then you will have secretions. Secretions will depend on the location. It can be more, it can be less, depending on the type. Remember the secretions of the pituitary gland we have. Do you remember the first table that I told you that you have to know? Mm-hmm. Okay, so if you remember, we will be fine here. Growth hormone, where do we release it from? And what's the other name? Anterior pituitary. And what is it important for?
Growth.
Growth, right? Stimulate protein synthesis so you grow more, right? So growth hormone is released, hyperfunction versus hypofunction, okay? Hypofunction first, this is the easy one, dwarfism. You know the dwarf? You become dwarf, that's it, dwarfism. Low secretion, dwarfism. But remember this, when I tell you about hyper or hyposecretion, you have to tell me the age first, okay? Are we following? It's not necessarily, you have to, when I ask you, don't answer. What is the effect of high growth hormone? Don't answer. Tell me I have to tell you the age first. It depends, right? What's the effect of hyposecretion? Tell me the age, right? So if you are a child and you have hypothyroidism, you get dwarfism. What if you're an adult? Do you get dwarfism? Do you shrink? No. What's the need for growth hormone after that, after birth? After puberty. It increased blood sugar. This is the most important one. Increased blood sugar. So if you have hypo after puberty, hypoglycemia. Did you understand this? Before puberty, growth hormone is to grow. After, increased blood sugar. And by the way, we finished glucose, but you will still see something related to it. This is one of them. So what's the effect of growth hormone? Increased blood sugar. Increased blood sugar in adulthood. Now increased secretion, excessive secretion. What's the effect of excessive secretion? What should you ask me?
The age.
Tell me the age first, right? If this is a child, he will get gigantism or giantism. Like everything will become larger, but homogeneous. Like he doesn't look abnormal, he look huge. And this is called giantism. How about adults? What if did you finish growing? Can you become any taller? Can your height increase after adulthood? Can you?
No.
No. You can decrease, you cannot increase. Right? So you'll not grow anymore. So Abraham Lincoln, do you remember this president? He's got this type of tumor. He was an adult and he got the tumor late. Can he become any taller? The height increase? No, it's not going to increase. He is going to increase his blood sugar. But let me give you an exception here. Even though you do not grow longer, but there are certain parts of the body that can still grow a little bit. And these are called the acros. Here. 1, 2, 3, 4, 5. These are called the acros, the extremities. 1, 2, 3, 4, 5. They can still grow. You're not getting any taller. Your height is not increasing. This is acromegaly. Look at the picture, and you can find pictures yourself. These are the different ones, but look at this. This is him when he was younger, and this is after he got the acromegaly. Look at the physical features, how it looks different. And if you have two pictures compared to each other, you will not see any change in the height, in his height. But you will see change in his fingers, in his foot, in his extremities. Did you get this?
Yeah.
Do you understand? Okay, anything that's related to sugar, you still need to know. We're not done. Okay? Antidiuretic hormone. What was the function of antidiuretic hormone again? From the first table? Keeping your water or stopping your losing water. It's the same thing, right? Which is water reabsorption. Reabsorption. Now, if you have less and if you have high, ADH. If you have less ADH, you get something called diabetes insipidus. Diabetes? Didn't we say diabetes before? Diabetes mellitus? This is another diabetes. So let me tell you what diabetes means in the first place. Because diabetes have nothing to do with sugar. Diabetes mellitus is sugar. But diabetes itself, it means a lot of urine. Urine. You make a lot of, which is polyuria polydipsia. Polyuria polydipsia. But this is diabetes. Now, when I tell you this person is having polydipsia and polyuria, you say diabetes. What type of diabetes? It depends. Now it depends. If it is because of sugar, you call it mellitus. You know what mellitus means? Sweet. The sweet diabetes. So this is the one that's related to insulin and blood sugar. But this one is insipidus. Insipidus means low ADH. Low ADH. Okay? So you don't have enough ADH, you lose a lot of water. Are we following so far? We good? Okay. So in each abnormality, you need to know the name first. Is it diabetes insipidus or SADH? SIADH, which is syndrome of inappropriate ADH, which means you have a lot of ADH secretion. Most likely it is, benign tumor. It goes without saying, all of them. Anything. When I ask about hypersecretion of anything, what's the first thing that comes to your mind? Benign tumor. So, syndrome of inappropriate ADH means you secrete a lot of ADH, right? So a lot of ADH, you're reabsorbing a lot of water. You have increased level of water in the blood, right? Increased level of water in the blood. And this is a problem. Why? Because dilution. If you have 5 liters of blood, now it's 7 liters because you added 2 liters of water. Don't you think that everything will be diluted? Right? Can you get juice and add water to it? It will be diluted, right? Same thing. If you reabsorb a lot of water, more than needed, everything will be diluted, and this is a problem. Sodium will be diluted. Sodium will be the same amount of sodium in higher amount of water, which is called hyponatremia. And hyponatremia is bad, right? Diluted. So what's the treatment for that? For diabetes insipidus, it's usually adenoma. If it is something that you can manage, medical treatment, that's fine. Replace or surgery, if it is pushing. SADH, give them diuretics and sodium supplement. What's diuretics? The water bells. What does it do? Yes, so you get rid of the extra water. You don't have the dilution anymore, right? But you can give them a little bit of sodium as well. Thyroid. I want you to differentiate between the following two: size and function. When we talk about thyroid, pay attention to this. Are we talking about size? Are we talking about function? Is it the same? It's not the same. Increased size doesn't mean increased function. You can be increasing size and useless. Generally speaking, if the size of the gland is increased, the thyroid gland, you call it goiter. Does that mean increased function? Not necessarily. Not necessarily. So what's goiter? Enlargement of the size of the thyroid gland. Is it producing more or less? I don't know. I don't know. It's just the size is increased. Did we get this point? Function, you call it hypo versus hyperthyroidism. Did you get the difference between goiter and hyperthyroidism? Goiter just increased size. Hyperthyroidism means increased function. You're secreting more, right? Did you get the difference? So you need to differentiate between those. And that's why you call the goiter, sometimes it's toxic goiter, sometimes it's not toxic. If it is goiter, mean increased size, plus hyperthyroidism, like the size is increasing and you're producing a lot of thyroid, you call it toxic goiter. It's toxic. It means you're producing a lot, toxic. Sometimes it's not toxic, like I feel your thyroid gland, oh, it's enlarged. Do you have hyperthyroidism? No. I measure your thyroid, it's okay. Or sometimes even less. So these are two different things to separate. In the endemic goiter, it's something endemic, like this area specifically the areas of high mountains, these areas will have goiter. Like you get a sample of 100, you'll see like 20 of them having goiter. So it's endemic in this area. Why? Because you don't have enough iodine, low iodine level, in the soil and the food. For some reason, the soil there and the water there in the high mountains does not have enough iodine. And iodine is the raw material that's used to make thyroid hormone. Are we following? Okay. So iodine is for endemic goiter, specifically in high mountains and the Great Lakes. High mountains and Great Lakes. These two areas specifically, they have less iodine. Okay? Goitrogens. These are the things, goiter generators, something that increases the size of your gland. Okay? There are some foods that block the synthesis of T3 and T4, so you will have feedback to stimulate the gland, and the gland will become larger. Is that hyperthyroidism? No, it is not. Did you understand this? Something happened that lowered the T3, T4, or lower the thyroid hormone. Negative feedback, you go to the hypothalamus, secrete more, the gland will be stimulated, it become larger. Goitrogens. So lack of iodine will cause goiter anyway, irrespective. of hyper or hypo. Oops. Endemic goiter, look at this. Look at the thyroid. This is called goiter. Is it hypo or hyperthyroidism? You don't know. You don't know. You're just seeing the gland enlarged. You call it goiter. That's it. Hyper or hypo, I don't know. So hyperthyroidism is the first one, which is now the function, okay? Now the function. You're secreting too much thyroid. And you have to know the name. If there is a name like this, you have to know the name. Graves' disease. Graves' disease, which is hyperthyroidism. And this is most likely it's an autoimmune disease. Let me tell you this, just to simplify. Thyroid hormone have a lot of functions. But the most important of all, just to wrap it up, all of them together, increase overall metabolism. Increase overall metabolism. Did you get this? Generally speaking, a lot of functions, but the bottom line is increase overall metabolism, meaning you increase all the reactions. And because you increase all the reactions, you need more oxygen. And because you need more oxygen, you breathe more. And because you need more oxygen, heart rate goes up. So everything is built on the top of increased metabolism. Did you understand what I mean by this? Increased metabolism. This is your clue. So when you increase your metabolism, everything goes up. You increase more, you produce more heat. You sweat, right? Produce more energy. You don't need to sleep more. Insomnia. You produce a lot of reactions, a lot of energy. You become hyperactive. You sweat. You get high body temperature because you're producing a lot of energy and a lot of heat coming from the energy. Did you understand the whole process? It comes from this. If you understand this, you get everything. Increase overall metabolism. If you increase overall metabolism, you increase all reaction. If you increase all reaction, you produce more heat, more energy, you become hyperactive. You don't need to sleep much. Did we get the idea? It's all linked together. Toxic goiter is a combination of hyperthyroidism and increased size. Exophthalmos is one of the problems with Graves' disease. Some people have it, some people don't have it. What exo means? Out. So exophthalmos is the eyes protruding out. And all what we need to know here is, in those people, some deposits occur behind the eye, pushing it out. So blinking will be less, and the eye will be protruding. Did we get this? This is all what we need to know here.
Can that be reversed?
Yes. If the condition is improved, this deposit behind the eye will start to disappear and the eye will go backwards. But it needs a long process to go. Okay? Exophthalmos. Thyroid crisis. If the thyroid secretion increase all of a sudden, it can lead to hyperthermia and heart failure, and you need to know this. Thyroid crisis. What is the thyroid crisis? All of a sudden large increase of the thyroid hormone. So the metabolism will increase dramatically, leading to hyperthermia or fever and heart failure. Did you understand this? It's coming from increased thyroid. Look at this exophthalmos. You think that the eye is getting bigger, but it's not. Look at this. Don't you think the eye is big? It's not. It's just pushed out because of deposit behind it. Exophthalmos. The other thing is hypothyroidism. And listen to this. For hyperthyroidism, just like growth hormone. Remember growth hormone. When I ask you growth hormone increase or decrease, you have to ask me what? Age. Same thing here. Hypothyroidism. What happened with hypothyroidism? You don't answer. Tell me the age and I'll tell you what happened. If it happened in utero, so the baby is not having enough thyroid, he will get a condition called cretinism. Cretin. Cretin is dwarf. He will become dwarf, okay, and will look like this. Moon face, central obesity, he will look like this, okay? Cretinism. And he will have some sort of mental retardation because thyroids stimulate overall metabolism, increasing the metabolism of the brain. So cretinism, this is if he's in utero, congenital, something he's born with. Inside his mom, his thyroid will small. Right? Hypothyroidism, congenital. He's born with it. and he will become dwarf like this. Short stature, round face, protruding tongue, the abdomen will be protruding, it will become bigger than normal, and so on. So what should be done there? This is the follow-up during pregnancy. They should get a sample from the amniotic fluid or something, and one of the things that they should measure, besides a lot of other things, there is AFP and a lot of things. One of them is thyroid. So if you get a sample and you know that the thyroid is low, you have to tell the patient you have a chance of a baby born with cretinism. Do you want to avoid that? Yes. We will give you and we'll give the baby thyroid, because if he is left like this, he will become cretin. And cretin is not something that's easy to treat. It might improve a little bit with treatment, but it will not be reversed. So this is the congenital hypothyroidism. How about the other thing, which is you're an adult, you're not born with it. You got it later on. Just hypothyroidism. Can be because of iodine deficiency. Hashimoto thyroid, that's something that you need to know specifically. This is an autoimmune hypothyroidism. Yes, you need to remember this name. Hashimoto thyroiditis. Hashimoto. This is a scientist who discovered hypothyroidism because of autoimmunity. You produce antibodies to destroy your own thyroid hormone. Hashimoto thyroiditis. Did you get this? Hashimoto thyroiditis. Sometimes it's surgical removal, sometimes it's a tumor, anything. What are the manifestations of hypo and hyper? Did you understand what I said first about the thyroid? Thyroid increase what? Overall what? Metabolism or metabolic rate. Overall. When you increase overall metabolism, what happens? Overall metabolism. More reactions, right? You produce more energy, right? More heat, right? Become hyperactive. And because you're doing a lot of reactions, you need more oxygen, right? You breathe more? Yes. Your heart rate goes up? Yes. These are all the manifestations of hyperthyroidism. Anything of what I said will go up. Did you get this? Can you figure it out your own? How about hypothyroidism? Exactly the opposite. Everything goes down, right? So are you active? No. You're not hyperactive. Did you get insomnia? No, actually you sleep more. You don't have energy, right? Do you have, is your body hot or cold? Cold. Cold. Those people, is the temperature good here in this room? It's okay. If somebody having hypo, some of us will have variations, but it's within average. Like if I ask most of us, will say it's okay, right? If I have somebody who's having hypothyroidism, you get in, or why don't you turn on the heat? It's too cold, right? Or somebody else with hyper will say, this is too hot, right? Did you get where is it coming from? Overall metabolism. So this will give you everything. How about the body weight? Hyperthyroidism, how the body weight goes up or down? A lot of reactions, you're using all your resources, break it down to get energy, you lose weight. So weight goes down. Hypothyroidism, on the other hand, you leave everything, you don't break it down, you get bigger, right? BMI become larger. There's one specific thing here that's called myxedema. And yes, you have to remember this. Hypothyroidism can lead to myxedema. Myxedema. It's edema. Do you know the edema?
Swelling.
Swelling. Like you press on it like this. You press. You feel it swollen. You press on it and it goes down. Right? This is called edema. But it's non-pitting edema. What's non-pitting edema means?
It doesn't leave a impression.
Exactly. It does not leave a finger impression. Pitting edema, you can pit it, meaning you push it down and leave, you see an impression of your finger. This is not the case here. This is non-pitting edema. And this is myxedema. And myxedema can lead to coma. What does it mean? Myxedema, you have this edema, and the thyroid goes down enough that everything, all reactions are deteriorating. To the extent of not having enough energy to the brain, you can get into coma, and you call this myxedema coma. This is a comparison between the two, and everything here makes sense. level will become low versus high, metabolic rate low versus high, skin become cool, here become warm and flushed. Tolerance to temperature, cold intolerance, heat intolerance. I told you a person is coming in and you say this is too cold versus too hot, right? Cardiovascular system, bradycardia, tachycardia, nervous system, lethargy versus restlessness, body weight, increase, decrease. The next is adrenal glands. We have the adrenal medulla and the adrenal cortex. Adrenal medulla, there is a tumor that you have to know that's called pheochromocytoma. You have to remember this name. Pheochromocytoma. Pheochromocytoma. What's a pheochromocytoma? This is a tumor of the adrenal medulla. Do you remember the table in the beginning again? Do you remember what the adrenal medulla is secreting? Epinephrine and norepinephrine, right? And this is sympathetic? Sympathetic. So what do you think will happen with pheochromocytoma, which is a benign tumor of the adrenal medulla? Do you get more or less epinephrine, norepinephrine?
Less.
More.
It's usually more. Okay? It's a benign tumor. So it's not destroying the tumor. Yes, I understand it can be more or less. Yes. But I'm telling you here it is more. Okay? So what will happen? What will happen is there is no emergency, there is no stress, you're not fighting, but your body is reacting as if you're fighting. Did you understand this? So a lot of epinephrine. So I'm resting, I don't have any problem. But my heart rate is going up, I'm breathing fast, I'm hot, I have tremors, right? I'm stressed out. Like there is a sympathetic situation and I ask, do you have any problem? No, I don't know what's happening. Are you fighting? Do you have a problem? I don't have anything. But you're exactly like you are under sympathetic situation. So we have tremors, headache, palpitation, sweating, increased body, respiratory rate goes up, everything as if you're fighting, but you're not fighting. So that's exactly what it is. Pheochromocytoma is like you're fighting, but you're not fighting. Just have a tumor. Tumor of the medulla. How about the cortex? I want you to memorize the following about cortisone. For this or for anything else. And I mentioned that before, I'm repeating it, you have to know this. Not just for this chapter, for anything. You can answer a lot of questions because of this. What is the function of cortisone? Anti-allergic, anti-inflammatory, immunosuppressive, decreased calcium absorption, anti. So these are the things that will go down. What are the things that goes down? Allergy goes down, inflammation goes down, immunity goes down, calcium absorption goes down. 4 go down. This was not in the slides, by the way. I put it together like this just to make it easier for you. This is not a slide there, but I want you to know it because this will be more organized in your brain if you get it this way. So less. 4 less and 4 up. Okay? If you remember this, it will help you a lot. Not just this chapter, all over. Remember it. Allergy goes down, it's anti-allergic. Inflammation goes down, anti-inflammatory. Immunity goes down, immunosuppression. Calcium absorption goes down. What happens if you have calcium absorption goes down? Your bone will become weak, osteoporosis. Are we following? What increased then? Blood sugar increase. Do you mean cortisone increase blood sugar? Yes. Growth hormone increase blood sugar? Yes. Glucagon increase blood sugar? Yes. Is that all linked to the first part? Yes. Are we following? Epinephrine increase. Write it down. Write it down. What increase the blood sugar? All of the following. Glucagon, epinephrine, cortisone, growth hormone. All of them. Epinephrine, glucagon, cortisone, growth hormone. All of them. All of them. I know we did the diabetes already, but I'm adding this. Write it down. Important. Blood sugar increase. Sodium increase. Blood pressure increase. Body weight increase. So if you know somebody who's having a problem with the adrenal cortex or he's having a lot of cortisone treatment, you will see his weight going up. You will see his blood pressure going up. Measure the blood pressure, it will go up. Sodium, increase blood sodium because the cortisone have an aldosterone-like effect. Yes?
Are you talking about like the cream or like the
No, the cream is just local. It doesn't do anything.
'Cause I have,
Yes, no, it doesn't do anything. It's the pills or the shots. Any one of those. Something systemic. So it will cause all of those. Blood sugar goes up. Hyperglycemia, increase. Sugar, sodium, pressure, weight. Did you get this? Sodium, pressure, sugar, weight. Sugar, sodium, pressure, weight. Sodium, sugar, pressure, weight. All of those will increase. And that will give you everything, by the way. So if you go to the first problem, which is hypersecretion, this is called the Cushing syndrome. So what are the criteria of the what do you think the reason for Cushing syndrome? I'm telling you, it's excessive glucocorticoids. What's the reason? What's the most common reason? That we mentioned it 10 times so far. Benign tumors. Benign tumors, okay? All of these are tumors, by the way. These. Oma. So adrenal tumor, pituitary tumor that affect, ectopic tumor that affect, iatrogenic. What iatrogenic mean? What's iatrogenic? We did this before. Iatrogenic means generated by drugs. You're taking medications that have an effect that's similar to cortisone. Iatrogenic, it's not here by the way, it's not just here. It's just a generic word. Iatrogenic caused by drugs, caused by medications, or substance abuse. Here is how the Cushing syndrome looks like. Look at all these. So the moon face, the red cheeks, the fat beds in the back, buffalo hum. Look at these red striation looks like this. This will become smaller, and in the middle, this will become central obesity, and so on. So what will happen with Cushing syndrome? All what I talked, you remember what's increase and what decrease? Do you remember 4 and 4? You will get everything because of that. Just everything that I mentioned already will become more. Are we following? Do you know what I mean? What happened to your immunity? If you have Cushing syndrome? Down. It will be suppressed. Yes. Goes down, right? Well, what happened to your blood pressure? Increase, right? What happened to your sodium level? Increase, right? Body weight, increase, and so on. If you get this 8, it's more of this. It's more of this, and it will cover everything. What happened to the blood calcium? Decrease absorption of calcium, osteoporosis, right? So if you get the first 8, you will get everything else. And what happened to the blood sugar? Increase, hyperglycemia, right? Just to add one more thing here, that the main thing about cortisone, or the first thing that we need to know is, they call it this name, by the way, stress hormone. Stress hormone. They call it the stress hormone. You secrete a lot of it if you're stressed out. It will manage your body to interact with the stress. It's a stress hormone. So if you have a lot of it, you will have emotional lability. So you have emotional abnormalities. Okay, you cannot deal with, or you have abnormal interaction with stress. Here are the criteria that we talked about. The opposite of is Addison. You know how I remember Addison? Addison, add more cortisone. Addison, I want you to add more cortisone. So it's less cortisone. This is how I remember it. Remember the way you want. You have to remember it anyway. This is how I remember it. Addison is the name of a person, by the way. But I remember it, add. It's low. Add. You need to add because it's low. Addison. It's exactly the opposite. And it can come from hemorrhage, infection, anything that destroy, or autoimmune. And the manifestations are the exact opposite of what we mentioned before. Sodium goes down, body weight loss, fatigue, blood sugar, blood glucose. And this is a comparison between those two. It's good to take a look at it. But it's mentioning exactly what we talked about, just comparing them together. And this will make it for this chapter.